Twisting the shaft in the fingers without angulation, it just rotates, whereas with angulation, torque steering is easy. When fully angulated, adding lateral has only slight additional effect. Over-angulation should be avoided as far as possible. The walking stick handle effect simply pushes the loop in and doesn't slide around, whereas de-angulating allows the scope to slide around because there's less friction. Movement of the tip of the colonoscope depends on it being free and having space to move. If it's wedged against the surface or fixed by adhesions, the shaft moves but the tip doesn't. This is the problem in diverticular disease, especially where pericolic adhesions hold the tip and stop the endoscopist manoeuvring. One of the tricks is to torque or twist around bends, but also to torque shaft loops, which usually run clockwise up and over the pelvic brim. Anti-clockwise torque in most colons worsens the loop. If shaft torque in one direction is being used to control a loop, tip steering in the other direction must be by using the angulation controls, because torquing in the opposite direction lets the loop reform. As well as pushing or pulling, the right hand is busy torque steering, coordinating with left-hand angulation so as not to lose the view. The rectum, which is capacious enough, is an ideal place to practice rotating the view. It's possible to twist 360 degrees around. Rotation like this does mean hard work for both hands. When targeting a polyp, for instance, it's important to get it into the bottom of the view. Shaft torque with control knob angulation allows accurate targeting and makes biopsy or destruction easy. Also, during insertion, twisting to follow the axis of the lumen, corkscrewing or torque steering, is very efficient. Avoid thrashing around with purposeless movements, and in particular, avoid redouts. Don't ever push with a redout like this. Sometimes the view may not be perfect. Here it's following the longitudinal bulge, up and under the fold. Push through for a few centimetres or a few seconds is then permissible until the view is regained. A perfect view isn't needed. Use enough air insufflation to see the lumen, but don't over-distend it. Steer over the top of any fluid pools, insufflating to create a space and pass through. Sometimes, if there are difficulties and a reasonable view isn't being obtained, it's quicker to change patient position. This will allow the air and the fluid to reposition to some extent. The lumen can be lost behind a fold. Looking for small visual clues will find it again. The centre of converging folds should be the lumen, the darkest side of the mucosal view should be nearest to the centre, and the darkest part of a fluid-filled colon should be where the lumen centre is. Close-up steering is helped by looking for curved arcs. Arcs may be caused by haustral folds, by reflections from the circular muscle fibres under the surface, or by highlights reflected off the surface, even by the microscopic innominate grooves when you can see them. In large colons, a useful clue can also be one of the 3 longitudinal muscle bundles, or tene coli. If the view is lost, don't just move the angulation controls around randomly. That usually makes things worse, and you get more lost still. When lost, there's a 3-point action plan. Blow air, pull back slowly, and the vessel pattern slides away in the direction of the lumen. Keep steering movements slow and controlled. Follow the lumen only at the rate that you can steer, so that everything is smooth and most movements are a few degrees only. Some people, especially those with small hands, do use the right hand on the lateral angulation control when necessary, fixing the shaft by leaning on it with the thigh. Pull back frequently during insertion, especially when there's any unnecessary loop, the left hand angulating to keep the view up the centre. Use pullback movements combined with gentle torquing. Find the correct axis for each bend. Steer in the direction of the lumen and twist around to follow the lumen, slowly and with control.